Morning, guys. Again, I'm Don. I'm one of your PG-by-4s. I encourage you guys to talk amongst yourselves for this one. When I ask questions, shout it out. Try to have a little fun with it. So this is a case we had at Kings County recently. Special thanks to Dr. Silverberg, Dr. Egan, and Dr. Weissman. So we have a 37-year-old gentleman. He has no past medical history. He's presenting to Kings County in the middle of January, complaining of 4 days of fever. What do you guys want to know about this gentleman? We get a lot of these. Yes, travel. No, he's not been to the Wuhan province of China. All right, so you know he's going to travel. He has recently come from Nigeria. Right? Exactly. So we're going to build that differential in a second. But what questions do you want to ask him, symptomatology-wise? Because there's a lot of things that could potentially be. Yeah, he started having them for like 4 days.
And are they primarily throughout the day? Are they only at night?
Right now, they aren't. We specifically ask, are they cyclic? Do you have them at any worse in the day, worse in the night? And no, there's no real chronicity to them.
Why did he come to the hospital?
Because the fevers have been severe. He's had rigors and myalgias, and neck is starting to get a little stiff. Yeah. There has been no cough, no rhinorrhea, no photophobia. Okay. So aside from the headache and the myalgias and the rigors and the neck stiffness, he doesn't have any other symptoms to report. He did not take he did not take prophylaxis. He was not taking any malaria prophylaxis. He did not get vaccination for yellow fever. Right? Anything else at the moment? No rashes. I like that. Rash is important. He is sexually active, yes. He says everything hurts, Doc, not specifically joints.
Did he go anywhere else besides Nigeria, like traveling through? Did he go to any other?
He did not. He did not go to any of the countries in Africa. Did not travel anywhere else. Just flight there, hung out with family. Never been to Nigeria before. Flight back.
Has he ever had malaria?
He's not. He's been in Brooklyn his entire life. Not that he really knows. He was on the plane. Imagine some people probably sick on the plane, but nobody that he knows is sick. No.
How long was he in Nigeria?
He was there for 2 weeks. He just got back. Got back like 48 hours ago. See family. Yeah, visiting for the first time. Yeah. So he comes through, he's cleared through CCT, vitals on presentation, he's febrile to 102.8, his heart rate's 120, his blood pressure's a little on the soft side, 99/62, respiratory rate's 20. Sepsis clearance, right? Sepsis labs were sent. Yeah, it was. All right, so he's actually fairly well appearing. He's appears ill but not toxic. On his exam, the things that you note, everyone thought malaria at first, but he's anecteric, his neck's nice and supple, his lungs are clear, his cardiac exam is only remarkable for tachycardia, his abdomen's nice and soft, he's got full range of motion, he's alert and oriented, times 4, he doesn't have any apparent lateralizing deficits, and you don't totally strip him, but you check his extremities, check his chest and his back, you don't see any rash. Okay? So what are some things on our differential? Carolina right off the bat said malaria. You guys should all be thinking malaria. You are all going to see one by the time you graduate. I promise you. What else? Flu, HIV. I love that. Yes. Dengue. Yellow fever. Dr. G? Typhoid. I didn't think of typhoid. Typhoid. TB. Regular coronavirus, not the novel one. Regular one. Ebola. We had typhoid. Yeah, Ronnie's given us B-cell lymphoma. He does have constitutional symptoms. EBV. What's that? Trypanosomiasis. Good. So I didn't put that on our differential, but we have 2. We'll talk about which trypanosome, which illness it would more likely be when we get to our differential. Anything else? Plenty of weird stuff. No? All right. I think that was a great exhaustive list. There's some that I didn't put on mine. So we're going to head over to the CDC website to help make our differential, okay? And we see some weird things, right? Right now, a polio outbreak in Africa, right? Yellow fever in Nigeria, there is an active yellow fever outbreak. Monkeypox, I'm familiar with a lot of strange things. I'm not very familiar with monkeypox. As well as Lassa fever and measles. Currently, actually, measles outbreak in Nigeria. And Brooklyn, yes. So some strange things that we need to be thinking of. A lot of these we don't have the ability to rapidly test for, so your history and your physical are going to be really important, right? What is monkeypox? That was the one that I saw. I was like, seriously, what is monkeypox? This one's actually, yeah, from either monkey scratch or eating infected bushmeat. It is similar to smallpox. However, it is thankfully not. It doesn't have a high mortality rate. Okay, so, oh no, my animation went away. That's right. So we went through our differential. Okay, so I kind of thought of the common things that are common, right? Pneumonia, influenza, URI, those sort of things still on the radar. It doesn't have the cough though. Acute HIV, I want us all to I put that one back in last minute. It's something that we don't always think about when we're making our differential for febrile patients. It should be. Pharyngitis, meningitis, and UTI and pyelo, again, all fairly common things that we're going to test for. But from the CDC website, we have all these now regionally specific diseases. And a lot of these we don't have the ability to rapidly test for. The two that I thought of that we didn't discuss were chikungunya and dengue. And then we had trypanosomiasis. There's two that we can talk about there. Quickly, I want to go through with you guys. What are the hallmark features of malaria? Yeah, relapsing remitting fevers, cyclic fevers, and it's a hemolytic fever, right? So you're going to have a polyicteric patient. They're going to be jaundice looking. What about Lassa? What is Lassa? There's a big public service announcement in Africa about this. They have a whole bunch of signs. It's shows a rodent, puts a slash through it. Lassa is when it's mild disease, it's kind of just mild, just fevers. But as it progresses, you get sore throat, vomiting, diarrhea. It is one of your viral hemorrhagic fevers, and it is spread by rodents. That's from the Lassa virus. We talked about monkeypox briefly. Monkeypox is going to look like smallpox. You're going to have a lot of cutaneous manifestations. Yellow fever. What's yellow fever look like? Yeah, high fever, jaundice. It's going to look very similar to malaria. Okay. Measles. What about measles? Yeah, 4 Ds and 3 Cs, right? Cough, cries of conjunctivitis, and 4 days of fever. So you have 4 days of fever, your cough, cries of conjunctivitis, and Koplik spots, right? So we should be looking for cutaneous manifestations again. Polio, don't think about polio very much. What is polio? Polio causes what? Paralysis, myelitis, right? So we should be looking for neurologic deficits if we thought polio. Chikungunya, joint pain, right? Big thing in chikungunya is going to be joint pain, okay? What about dengue? Break bone fever. I heard someone say it. Who said it? Nice. Yeah, good. And then there's a stereotypic rash with that. You're going to start off, it's going to be just a blanching area of erythema, but then eventually the whole patient becomes kind of erythematous, and you have islands of white and a sea of red. And itchy. I didn't know that, and apparently very itchy. There you go. Some things that I didn't include on here. Just always think about with travel, the hepatitis virus, especially hepatitis A, right? And then we said trypanosome. There's 2 trypanosome illnesses, right? Interns, anybody remember what the 2 are? Cruzy. What does Cruzy cause? Chagas, which is going to be our cardiomyopathies and stuff, so probably not as much this patient. What's the other one? Not in Africa. Yeah, so Brucey is African sleeping sickness, and that will present originally kind of like fevers, myalgias, and things like that, but then you're going to develop encephalopathy. Beautiful. So patient goes through CCT, and our sepsis labs are sent. Most of the workup was done in EKG in CCT actually. So the EKG is sinus tach. Going through the labs, the things that are remarkable: lactate 3.1. What do you guys think about the CBC and the comp on this patient? What's that? Thrombocytopenia, right? Whenever I see thrombocytopenia, I start worrying about either DIC or I start thinking viral illnesses. Sometimes your viral illnesses will cause either thrombocytopenia and also leukopenia. What was that, Dr. G?
Think about
Dengue. And then also, when I think, because I always kind of anchor on malaria, like, oh, you came from Africa, you've got fevers, you've probably got malaria. Like, I don't love to say that that's the first thing that my head goes to, but also the T-bill is only 1.4. If you're having hemolytic, what's that? Yeah. So again, unless he's sitting at 15, something like that. This one wasn't too. I didn't think malaria when I first saw these labs. Flu swabs negative, UA and chest X-ray negative. What are your thoughts? Anybody else have anything they want to kind of add to this? Why? Rithvik wants a peripheral smear. I want a peripheral smear. Cool. What was that? Amoebas. Yeah. My friend did that. Go ahead, Paul. It can. What is the I guess hallmark symptom or sign of, yeah, lepto. Yeah, the other one we didn't have on there either also was leishmania, but that's going to be mostly cutaneous manifestations and rash. Yeah. I mean, I wouldn't until I kind of saw those labs, and then I probably would because I don't know if they're hemolyzed or not. There is elevated T-billy, and the hemoglobin's like wishy-washy. But I think I would also maybe leave that to medicine. I don't know if I'd do it in the ED, but my medicine brain would do it. Right. Also, so back to here, right? After we get some of our labs back, I thought, right, pneumonia, influenza, URI, again, there's no symptoms of URI, the chest X-ray is clear. Pharyngitis, we physical examined our way out of. UTI, pyelo, our UA is negative. We're kind of left now with a lot of the viral infections, right? Meningitis, we still technically haven't ruled out, but it just doesn't look like meningitis, but it's always a possibility. I imagine though, 4 days, if you had meningitis, we probably wouldn't be having this discussion. Yeah, anybody else want to add anything, move anything up, take anything down? Typhoid, yeah, sorry, I didn't think about typhoid. Clearly, it's probably not typhoid, didn't make it to the slide, but typhoid. Yeah. You're still thinking less likely because he's kind of comfortable looking? A lot of other things. So probably not chikungunya either then, you think? Yeah, I'm okay with that. A call from the lab, parasite seen in peripheral smear consistent with malaria. Sorry, guys. I tried to make it more fun than just like malaria. Dr. Snip's like, come on, Doukas. Yeah. I thought probably not next to dengue. Why did I say probably not next? Oh, because it's one of your viral hemorrhagic fevers, and he doesn't have hemorrhage right now. And it's been 4 days. He should, at this point, probably start to have signs. But he did have low platelets, so it's potential. Yeah. Or the second attack. So yeah, dengue then probably could have stayed on there. Also because it's break bone fever, and he was fairly comfortable appearing. Yeah. Probably come off. So the last two then, so we're sitting there, yellow fever and malaria. So and acute HIV. So really, until we got that smear, we probably could have gotten fairly close to malaria. Good job, guys. You guys are so smart.
And even though he wasn't anemic yet, it suddenly can start bursting and go down. I've seen that.
And
and if that was negative, you still probably, if you're still suspicious, should do up to 3.
Yeah, and so you could send blood parasites. You could send for malaria spear specifically. Those two things are different. I actually don't know what separates them at the lab, though. I'm not going to pretend that I do. This gentleman, he'd actually, because he'd never been to Nigeria before, he'd never had malaria before, He did not take prophylaxis. We did not know his parasite load. This gentleman was put on OBS because of the thrombocytopenia. They repeated the CBC. The platelets did not get better. And there was concern for black water fever. Right, we'll get there. Great question. So I'm going to go through some of the signs and symptoms before I hand you over to Dr. Silverberg. So malaria, some of the systemic manifestations, again, the signs and symptoms. You guys, we talked about it. Cyclic fevers, jaundice, hepatosplenomegaly. It's really going to look, they're very non-specific constitutional symptoms, right? I think you guys are all kind of familiar with that. Once we get further along in the disease process, when the parasites kind of sync up in their life cycle, you have the more typical picture of the cyclic fevers. If it's left untreated, these patients can get quite ill. They can develop hypoglycemia because of impaired gluconeogenesis. They can develop shock and DIC. They can go into ARDS. They can start to have pulmonary manifestations. They can go into multi-organ system failure. They can develop cerebral malaria. This is not malaria that infects. It's not actually infecting the brain parenchyma. They believe that it's caused by a high parasite load in the microvasculature. This GIF is the only one I included. I love it. It's because of the seizure scene from Animal House. So the risk factors for cerebral malaria are young age, patients that have never had malaria before, poor nutritional status, and HIV. It really depends on how immunocompromised the host is, how virulent the virus is, increased risk if it's plasmodium, if it's falciparum, and if you have a history of splenectomy. So those are the risk factors for cerebral malaria. If you do end up doing an LP because you realize your patient's encephalopathic, there is an elevated cerebral pressure, opening pressure. However, it's going to look like a aseptic meningitis probably. Maybe elevated WBCs, but can't be guaranteed. The real issue with this too is if it's untreated or if it's treated late, the long-term sequelae of this, patients can develop cerebral palsy, cortical blindness, deafness, epilepsy, language deficits in kids. This can be catastrophic if it's left untreated or treated too late. And then black water fever is it's renal failure with hemoglobinuria. And this is caused by cytoadherence. What happens is that you have parasitized and non-parasitized RBCs. They adhere to the small blood vessels and they cause infarcts. There aren't infarcts in cerebral malaria, really. It's not a hallmark sign on autopsy when they check out these patients, but you do see it with black water fever. It's typically when your parasite load is greater than 4, and again, most common with falciparum, which is our most virulent strain. Any questions? Hand over to Dr. Silverberg. Thanks, guys. Thank you.
All right, thanks, Don. That was great. I apologize. I sound like crap because I got sick. I worked one shift in peds. One shift. That's all it's done. But I did have coffee and cough medicine this morning, so I may be talking fast. All right, so this is what we're going to cover after Don's great lecture on symptoms. We'll talk about some of the statistics in malaria, and then how it affects you, what the organism is, what the vector is, and then how to make the diagnosis, and then prevention and treatment. So malaria has a 10 to 30-day incubation period, depending on which bug it is. And Don talked a little about falciparum, but there are actually 4, well, there's 5 species, but only 4 really infect humans. Some data from 2018, there were 228 million cases worldwide and 405,000 deaths. 94% of the malaria cases happened in Africa someplace, and 95% of the deaths happened in Africa. So it's a big, big, big problem there. If you have HIV, much more likely to die from malaria, and if you're a child, much more likely to die from malaria. You'll notice that they're pretty much clustered all around the equator. It only happens in warm places, but there were 1,700 cases in the US last year. And this is all probably travelers coming back from an endemic area. So it's a single-cell parasite of the Plasmodium species, and like I said, there are 5 of them, but only 4 infect humans. So falciparum is the most common one, 75% of infections. Then you have Vivax, ovale, malariae, and Nowisi, which is only found really in monkeys and primates. I thought it was interesting, like, why is falciparum so much worse than the other malaria? So I did a little reading on it. And what happens is when the falciparum infects your red cells, it has some protein that goes to the cell surface that's very sticky. And that protein sticks to the endothelial walls, and it sticks to the other cells. And what it does is it prevents the malaria from moving around the body, or the malaria-infected cells, and they don't go to the spleen. And you guys know that your spleen is responsible for removing bad cells from your circulation, cells that look weird. So if they never make it to the spleen, they never get removed. So the malaria hold it to the endothelial walls and keep it there. All right, no lecture would be complete without the life cycle malaria. I see this every single time, and then I forget it promptly like half an hour later. We'll go through it real quick, but you get bitten by a mosquito that has malaria in its salivary glands. They go into your blood, and they make it to your liver. And in your liver, they start to form asexually more malaria. And these are the merozoites. They infect the red cells, they infect the liver cells, and they just keep producing more and more malaria. Every time your cells burst, they burst as a crop, and that's what gives you your cyclic fevers. Eventually, at some point, you get gametes that come out, male and female cells. All right, and these go into your blood and they circulate around. They don't burst, they stay in your blood. And then the mosquito bites you again, and it takes out the male and female cells. Once the malaria get into the mosquito's gut, the environment is different, and they're stimulated to come together and join to form a zygote. Once they're in the mosquito's gut as a zygote, they migrate out to the walls, get into the bloodstream of the mosquito, migrate up to the salivary gland, and your cycle starts all over again. So let's talk about the vector real quick. The vector is the Anopheles mosquito. The reason we don't have malaria here, transmission, is because we don't have this mosquito. And malaria needs the Anopheles mosquito to reproduce. All right, so this is what it looks like, little tiny bug. Of course, after it bites you, this is what it looks like. It's all filled with blood. Right? You guys know if you smash a mosquito on the wall, you get that big blood spot. That's when it's just finished eating. So what kind of testing can you do to diagnose malaria? Well, the big one is microscope. But it's only 50 to 90% sensitive. And there's a reason for that. It depends how good the person using the microscope is. In Kings County, we have awesome guys that see a lot of malaria, and they're really good at finding it. But it also depends on the parasite load. If you only have a 1% or a 0.5% parasite load, they're sometimes hard to find. But if you have a 10% parasite load, they're all over the place, much, much easier. They also have a serology test for it, and then also a PCR. But the problem with these tests is they're kind of expensive. And in the places that have the most malaria in Africa, they can't afford these tests, so they really don't do them. The last test they do is drug resistance testing. You guys may have heard that a lot of the malaria is now resistant to chloroquine, which is what we use almost all the time, many, many years ago. Now they can't do it because there's so much resistance. So here's what it looks like on blood smear. For all you guys who don't know, if you haven't worked with me, every time I diagnose a case of malaria, I go up to the lab and I ask to look through the microscope. A, because it's interesting. And B, if you take your iPhone and hold it up to the eyepiece, you can actually focus to the microscope and get pictures of it. So it's good for textbooks if you plan on writing a textbook. All right, so malaria can be the severe form or the uncomplicated form. So what makes it severe? Well, this is the World Health Classification System, and if you're altered, chances are it's gotten into your brain or has some other effect on you, that's considered severe. If you're so weak you can't walk or you can't eat, that's considered severe. If you have 2 seizures, not just one, but you have to have 2 seizures, the WHO considers it severe malaria. If you're in shock or hypertension, no kidding. If you have respiratory distress, malaria, as it breaks down your cells, all those broken pieces can get to the lungs and cause an ARDS-like picture. That's considered severe. If your hemoglobin is less than 5, if it's destroyed all your cells, or you didn't start with that many, that's considered severe. If you have a kidney injury, or a finger stick less than 40 if it's consuming all your glucose, if your lactate is greater than 5, and if your parasite load is greater than 100,000 per microliter. I mean, if you look at this list, that all makes sense. Those are all signs of any severe illness, not just malaria. So treatment depends on the species and depends on the country where you contract it, because there are different resistant patterns throughout the world. It also depends on your parasite load. If you need help treating malaria, the CDC has the malaria hotline. You can call them up and say, what do I do with this patient? They traveled here, this is what they look like, this is their vitals, and you can get all the information you need. You actually don't have to think. They'll just tell you everything. Treatment, there's a lot of drugs out there that treat malaria. Like I said before, most of us don't use chloroquine anymore, just because there's so much resistance to it. But it used to be the first-line drug because it was cheap, easy to get. Now it's the artemisinin that are used. Every single person that gets it should get 2 drugs, and one of them should be from that category. That's how most of us do it now. If you're pregnant or a child, you want to stick to the less dangerous drugs, so they use quinine and clindamycin if you're pregnant or if you are a child. Prevention is super important. If you go get the disease, you won't be affected from it. So you want to use drugs like DEET or picardins to keep it off of you, keep the mosquitoes from biting you. They sell clothing that are impregnated with these materials. It's a little more expensive, but I think a hospital bill is a lot more expensive, so you're better off not getting malaria. Buy that if you're going to go to someplace that's endemic. You should get this pants and shirts and stuff, hiking gear, that has the picardin in it or DEET in it. Nets are super important. We'll talk about that in a second, but it'll keep you from getting bitten. And they have something called indoor residual spraying. Mosquitoes, like humans, love to have a big meal and then go relax. What the mosquitoes do is they bite you, and then they go chill out in the wall. And they sit there and digest their food. So if you spray the wall with pesticides, then the mosquitoes land on it, and they die from the pesticides that are on the wall. So it's called indoor residual spraying. You can do mosquito control, too, where you eliminate all the standing water. I know when we have bad virus outbreaks in Long Island that are caused by mosquitoes, they make you tip over all your bird baths and get rid of like all the spare tires that have water collecting in them. So if you get rid of the water where the larvae live, then you have less mosquitoes. And then, of course, larvicides. They drive around in these trucks with big sprayers, and then they spray whole entire neighborhoods with larvicides. They have electronic repellers. It's not a bug zapper. It's actually a repeller. It makes a noise that the mosquito don't like. But a couple of the papers I read said it really doesn't work very well at all. They're probably just some gimmick to take your money. So the netting, it's really important that the netting go from the ceiling over your whole body and down to either the floor or be tucked in under your mattress. All right, so here's netting built for one bed, pretty easy to use. They make bedding for king-size beds, and of course princesses also. I actually did a lot of research on netting. I was looking at what to buy when I go away. So they make it for little tiny babies. All age groups are in there. Medium-sized children, even bigger children, and of course PPE. If you want to relax, hang out by the shore, you can also get netting in a hammock. And just to sit and watch NASCAR. And of course, if you don't have any trees on your property, you can get it built into the netting itself. All right, prevention. This is probably the most important part. All right. I used Malaria when I went to Haiti and didn't want to get malaria. You have to take it 1 week before and 4 weeks after you return. It's really important because the malaria stays in your circulation and can infect you if you stop taking it. Malaria also causes really intense dreams. It causes you to feel like you're tripping. Why most of us like taking it. And then, of course, if you're pregnant, sulfadoxine and pyrimethamine for the one if you're pregnant and you can't take the other drugs. They are working on a malaria vaccine, but it hasn't worked yet and it's not functional yet. So you're going to have to skip and stick with the medicines and not the vaccine. A lot of complications of malaria. It causes a lot of issues. Right? You can get severe anemia. Like we said, if you get down below 5, you're at risk of getting really, really, really sick. Hypoglycemia, malaria uses up some of your sugars. And then, like Don talked about, black water fever is pretty bad with AKI and a bunch of other injuries. You can get respiratory distress. Remember before we said that as the malaria bursts your cells, all those pieces of cell make it to the lungs and get strained out by your lungs. And then your body attacks all those cell pieces and gives you ARDS. You can get malaria hepatitis if it infects enough liver cells and not just the blood cells as well. And then encephalopathy, they say there's something called retinal whitening. If you do a fundoscopic exam with a person who has malaria, if their retina is really white, then you can say that they have cerebral malaria. Although, I don't know, most of us don't even look in the fundus anymore. Even when we try to, we can't see back there. It causes stillbirths, coagulopathy, shock, and of course, death in a certain number of people. So malaria has something called dormancy. When the hypnozoites stay in the liver, it kind of hang out there. They don't make it out to the blood, they only stay in the liver. So if you use a drug that only affects the blood-borne species, the blood-borne type, it won't kill the stuff that's in the liver. The one that does it the most is P. vivax. Some say Ovale do it too, but it's really P. vivax that stays in your liver and doesn't come out. And the only way to treat the hypnozoites that are in the liver is with primaquine. That's the only drug that hits the liver cells and gets inside the liver cells. Because the other drugs, the liver just breaks it down and gets rid of it and doesn't let it sit in there and hurt the malaria agent.
The only problem is with Primaquine I've seen is if you have G6PD, you get a really bad reaction with it, so you have to be careful.
Okay. Recurrence is when you treat somebody, but it's not enough of a treatment to get it all out of the blood. So you just get another reaction, but it still was there. Relapsing is when it was dormant in the liver, and reinfection, obviously, if you get rebitten by more mosquitoes, then you get reinfected. These words sound similar, but they have different meanings when you talk about malaria. So I thought it was kind of interesting that there's a genetic resistance to malaria. People with sickle cell are less likely to get malaria. And I read a bunch of things and I couldn't really figure out why, but it sounds like when your cells get infected by malaria, they sickle. And then all your cells kind of stick together. And when it's in the spleen can't find the cells that have malaria because they're surrounded by other cells, and they don't take it out of circulation. Thalassemia also gives you some resistance, as does G6PD. And then absence of your Duffy antigen. I had no idea what this was. I had to look it up. But Duffy antigen is just some chemoreceptor on your cell surface that if you don't have this receptor, you don't get malaria. Some people think it's because that's how malaria gets into the cells in the first place, but there was no real consensus on it. So in summary, malaria occurs in countries around the equator. It's Plasmodium species, and there are really 4 that cause malaria. It's the Anopheles mosquito that bites you and is the vector for it. It gets into your liver cells and your blood cells. P. falciparum is the worst kind you can get. It's the most dangerous. Prevention is super important with nets and prophylactic drugs. Use multiple drugs to treat, at least 2 when you're treating it, and watch out for complications. But the best way not to get to malaria is just to stay underwater where the mosquitoes can't bite you. What was that? Mosquitoes can't wear scuba yet. They don't have ears to put the mask on. Anybody have any questions?
A really great resource for all of this and all the cases